Good evening everyone, and thank you for having me for this very interesting webinar. And I've been asked to talk on a topic, trust me, is one of my favorite topics. It's a topic which I am very passionate about. It's a topic where I have done some amount of research as well, and at least given a lot of talks on, and that is drug-induced adrenal insufficiency. Now, when I talk about drug-induced adrenal insufficiency or adrenal insufficiency itself, a lot of doctors ask me that, how common is this adrenal insufficiency? Let me tell you. Today, in my OPD, I saw about 30 patients. Out of the 30 patients, and since I had to give a talk today, I just said that I just want to count the number of patients who come with drug-induced adrenal insufficiency, and so that I can give a kind of a talk on that. And I had 5 patients with drug-induced adrenal insufficiency. You'll be surprised. So out of 30, I had 5 patients labeled or either diagnosed for the first time or labeled already having drug-induced adrenal insufficiency. One patient was given dexamethasone by a local doctor for a long time. Another patient had tyrosine kinase induced adrenal insufficiency. Another patient was on immunotherapy. Another patient was on inhaled corticosteroids and on and off oral corticosteroids and presented with classical adrenal insufficiency. So the point I'm trying to make is that drug-induced adrenal insufficiency is very common, and for an endocrinologist like me, right? Of course, I have keen interest in this, so that's why probably patients there is a little bit of bias as well there. But at the same time, in a OPD of 30, if I see 5 patients with drug-induced adrenal insufficiency, that's a good number to really start with. So this is the outline of my today's talk. I'm going to keep it simple. I'm going to talk about 6 important concepts regarding this. We'll first talk about what is hypothalamic-pituitary-adrenal axis. We'll then talk about which drugs lead to adrenal insufficiency and how do they cause adrenal insufficiency. Then we'll discuss the core area, that is glucocorticoids, and how glucocorticoids produce adrenal insufficiency, and then very importantly how to taper glucocorticoids. Then we'll go on and talk about non-systemic glucocorticoids and how do they lead to adrenal insufficiency. We'll talk about some facts and figures about other drugs that can lead to AI, and then finally how to recognize and treat adrenal insufficiency. So this is the outline of my today's presentation. So let's start with this very basic concept. What is exactly hypothalamic-pituitary-adrenal axis? So you can see this figure over here, and this is something which I think most of the elite audience does not require any introduction, but just to reiterate, you have the hypothalamus on the top, right? And this hypothalamus, the hypothalamus produces CRH. The CRH acts on the pituitary gland and produces ACTH, and this ACTH acts on the adrenal gland producing cortisol. Now that's not all. Remember, there is a negative feedback. So the cortisol that is produced gives a negative feedback to the ACTH and also to the CRH. And this ACTH also has a short negative feedback loop to the CRH. So this is the outline of a typical HPA axis. Now, what are the external factors that can impact HPA axis? So if you have some environmental stressors, for example, patient has physiological stress, the environmental stressors can increase the CRH release from hypothalamus. And if you take glucocorticoids from outside, the glucocorticoids from outside directly inhibit the ACTH and CRH, leading to both secondary and tertiary adrenal insufficiency. So when you give steroids from outside, they produce a form of secondary and tertiary adrenal insufficiency. So this is basically the concept of HPA axis. Now, what is adrenal insufficiency? Very simply, adrenal insufficiency is when you have inadequate glucocorticoid and or mineralocorticoid produced by the adrenal gland. And then there are 3 basic types of adrenal insufficiency. So you have primary adrenal insufficiency, where the disease is because of the adrenal gland. So for example, let's say you have tuberculosis of the adrenal gland, or you have undergone an adrenal surgery, or you have congenital adrenal hyperplasia. All these conditions, you have adrenal gland which is not producing enough cortisol. Then you have secondary adrenal insufficiency that typically occurs when there is reduced ACTH production, and typically occurs, let's say, in a pituitary disorder. For example, if you've got a pituitary surgery, or you have a hypopituitarism, or you have Sheehan syndrome, all these conditions lead to secondary adrenal insufficiency. And tertiary adrenal insufficiency is you have a disease of the hypothalamus. So for example, let's say you have some tumor in the hypothalamus or the surrounding region, or you are taking drugs from outside. For example, you are taking glucocorticoids from outside, and that leads to tertiary. So glucocorticoids given from outside are the primary or the important cause of tertiary adrenal insufficiency. Okay, let's move ahead and come to the core topic, and that's the very important topic that we are going to discuss today. That is, which drugs lead to adrenal insufficiency and how. Now, a lot of you would have seen my other videos and other talks on glucocorticoids, on glucocorticoid-induced adrenal insufficiency, other things as well. But so there'll be some repetitions in a lot of these talks of mine. But at the same time, I'm going to give you some very crucial and important new information as well. So hang on to this, because there is something very interesting and something very important that we are going to discuss, especially the tapering of steroids, and that's something which I really feel is important. And also we'll discuss some important drugs which not many people know also lead to adrenal insufficiency. So just hold on to this talk, because we are going to discuss something very useful in clinical practice. So which drugs lead to adrenal insufficiency? Now, anybody wants to read a very good article on this topic, I think this is the reference here. You can see the reference here. This was published in the Journal of Endocrinology and Metabolism, JCEM, right? So this is the list of, and you can see here, the list of all the drugs that can lead to adrenal insufficiency. Now, something very interesting is that the new kid on the block, the new drugs which are, nowadays reported frequently to produce adrenal insufficiency are the monoclonal antibodies. We'll discuss a little bit about this topic as well. So you have all of these ipilimumab, nivolumab, these are all used in immunotherapy in cancer. And these are very, very important causes of adrenal insufficiency. In fact, like I said, of the 5 patients that I saw today, one of these patients was on monoclonal antibodies. Looking ahead, you have glucocorticoids, and all forms of glucocorticoids can lead to adrenal insufficiency. Of course, the potency of the glucocorticoid and the duration of the glucocorticoid are very important. We'll discuss these points as well. Interestingly, beta-2 agonists also have been reported to produce adrenal insufficiency. Some other hormonal therapies, for example, somatotropin, levothyroxine, I'll discuss a case of ours, megesterone, right? These are all hormones that can lead to adrenal insufficiency. And a very important drug, and I'll tell you a story of this one patient of ours, is abiraterone. This is used as a drug in prostate cancer, and this is also known to produce adrenal insufficiency. Then you have antiviral drugs like ritonavir. Ritonavir is used in HIV, and that's again leads to adrenal insufficiency. Fluconazole, itraconazole, right? Important drugs used for fungal infections, right? Then you have drugs used for Cushing syndrome. Naturally, drugs used in Cushing syndrome will lead to adrenal insufficiency. So you have octreotide, pasireotide, ketoconazole, metotane, metirapone, all of these lead to adrenal insufficiency. Protein kinase or tyrosine kinase inhibitor, I told you another patient today. Today we saw one patient with tyrosine kinase inhibitor induced adrenal insufficiency. Antithrombotics. Of course, heparin directly does not lead to adrenal insufficiency, but heparin can lead to, indirectly can lead to adrenal insufficiency. Alendronic acid also there are case reports of that. Very important drug, rifampicin. We'll discuss this, and another very important drug, tramadol. These are again 2 drugs we'll discuss in detail about how and why they lead to adrenal insufficiency. So these are some very important drugs that you cannot miss that can lead to adrenal insufficiency, and this is very, 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 very important that you know that these drugs can produce these condition and they can lead to adrenal insufficiency. Now jump to another favorite topic of mine, that is glucocorticoids, and how glucocorticoids produce adrenal insufficiency and how you will diagnose it, how you will treat it, right? So that is how that is what we'll discuss. Now this is a case, this is of course an old case of mine. I saw exactly similar patient today in my practice. So this was a 40-year-old patient from Haryana. This patient looks Cushingoid, right? So anybody, maybe a first year MD medicine student or even a first year, a DM resident in endocrinology will make this diagnosis very easily. This is a patient with classical features of Cushing syndrome, right? And this is another patient with Cushing syndrome, right? Now, we saw these patients who looked like Cushing syndrome. But very interestingly, when we did the baseline cortisol of this patient, they had low cortisol, right? Now remember, the cortisol values, we'll discuss this as a point, but cortisol value typically less than 3 are considered definitely low. So this patient had a cortisol of 1.2, which was low. So when you have a patient who looks like having Cushing's but has adrenal insufficiency, what is your diagnosis? The diagnosis is patient is having iatrogenic or exogenous Cushing syndrome with tertiary adrenal insufficiency. This is a complete diagnosis, okay? Exogenous Cushing syndrome with tertiary adrenal insufficiency. And which is the most common cause of Cushing syndrome in India, or in fact worldwide? It is iatrogenic Cushing. Exogenous Cushing's is the most common cause of Cushing syndrome. worldwide, right? So rather than endogenous Cushing, exogenous Cushing is much more common. Now, basically, how does a Cushing syndrome or how does exogenous steroid produce adrenal insufficiency? Like I already told you this, you take glucocorticoids from outside. Glucocorticoids taken from outside has a negative feedback on ACTH as well as CRH, and this leads to tertiary adrenal insufficiency, right? So the form of adrenal insufficiency that you see in this condition is tertiary. Okay, so this is a very important thing you have to understand. It leads to central or tertiary adrenal insufficiency, and here this one point you have to remember, right? So when you have primary adrenal insufficiency, you have deficiency of both glucocorticoid as well as mineralocorticoid. So you have to replace both the glucocorticoid as well as mineralocorticoid, right? So the glucocorticoid you will have, of course, you will give oral glucocorticoids, but mineralocorticoid you will have to go fludrocortisone, right? Whereas when you have secondary or tertiary adrenal insufficiency, right, like you have in case of exogenous steroid, in this the deficiency is mainly with glucocorticoids and not mineralocorticoids, and because you have just glucocorticoid deficiency, you just give glucocorticoids and do not give mineralocorticoid. There is no role of mineralocorticoid here. Okay, so this is a very important point which again physicians and clinical pharmacologists should be well aware about. Now, when should you suspect a patient having tertiary adrenal insufficiency? Now, patient will sometimes be screaming that, look, this is my diagnosis, but not always. Sometimes, a lot of the times, the diagnosis is not very clear, and in that case you will have to kind of dig through the patient's history and maybe search out the diagnosis, because sometimes the diagnosis may not be very apparent. So when do you suspect an adrenal insufficiency? So we have a patient who takes medications from, I mean, should not use the word, but from quacks for diseases like arthritis, asthma, COPD, PUO, right? Like the patient I saw today, the patient used to have some generalized weakness, and every time he would go to a local quack, he would give them an injection. This injection was most likely dexamethasone, right? And the patient would feel better, right? So that's a very typical thing that you see in smaller villages and other things. Typically, the patient appears Cushingoid, but the baseline cortisol is low, right? This is the classical feature. Sometimes the symptoms may be more subtle, right? Sometimes the patient will complain of a vague weight gain. Sometimes the patient will complain of some vague symptoms. Patient will have some skin lesions, right? So all these things is very important, and history taking is something which is very crucial for these type of patients. Subtle cases may be unexplained weight loss, skin changes, unexplained osteoporosis or vertebral fractures, unexplained hypoglycemia or hyperglycemia, right? So what happens is when the patient is on steroids, the patient's blood sugar goes up, but then suddenly the steroids are stopped, it can lead to hypoglycemia, right? So this is something which is very important. And hyponatremia, this is something very important, right? I mean, the number of cases in our hospital alone that have been diagnosed with adrenal insufficiency because they presented with hyponatremia after I joined the hospital has tremendously increased. Now, I again don't want to take credit for it. The point I'm trying to tell you is that a very important cause of hyponatremia is adrenal insufficiency. Please remember this. Again, very important point I'll tell you here, that when you have primary adrenal insufficiency, you tend to have hyponatremia with hyperkalemia, and when you have secondary or tertiary adrenal insufficiency, you just have hyponatremia without hyperkalemia, right? So you have normal potassium. In fact, potassium may be low or normal, right, in secondary or tertiary adrenal insufficiency, right? So this is a very important point that you should be all well aware about. Now, let's come to a very important area, that is, so we understood that glucocorticoids can lead to adrenal insufficiency, but now we need to know how and when to taper glucocorticoids, and what doses of glucocorticoids need tapering, what doses of glucocorticoids do not need tapering. So it's a very practical point that you have to understand. Now, this slide I think is something which I show many times, and this is very important. Which patients are likely to have hypothalamic-pituitary-adrenal axis involvement or HP axis involved with glucocorticoids? 3 rules. Any patient who has been on more than 20 mg of prednisolone for more than 3 weeks. Any patient who is more than 5 mg of prednisolone given in a non-physiological manner, it is at night time, for more than 2 weeks. Or any patient who has clinical features of iatrogenic Cushing syndrome and clinically looks Cushingoid, this patient is also somebody who has HP axis, likely to have HP axis suppression. So these 3 rules you have to always remember, and if you remember these 3 rules, it is very important that any patient who is on these kind of things require tapering, right? So these patients require tapering, right? So this is something which is a very, very important rule that you need to remember and you need to appreciate and understand. Right. So, to taper or not to taper, right? So, when should you taper? So, any patient who is on glucocorticoid less than 3 to 4 weeks of therapy, right, regardless of the dose, right? So, even if the patient has been on high dose, regardless of the dose, you can consider directly stopping without tapering. Any patient who is on long-term glucocorticoids, right, should, if the underlying, so you have to remember one thing that, if the patient's underlying disease is not controlled, right, and this is where I'll talk to you about the concept of therapeutic taper versus endocrine taper. If the disease is not controlled, you do not taper. Patients on long-acting steroid should be then switched to shorter-acting steroids, right, when you're tapering, and this is something, again, I'll discuss in a few minutes. And then when you reach the physiological dose, then you need to monitor the patient's HPA axis also while tapering. And one very important rule, which I have not written here, you have to remember, and that is that when you're tapering these doses, okay, when you're tapering these medications, sometimes the tapering period can be very, very long. In fact, the HPA axis may take from 9 weeks to, anywhere between 9 weeks to 9 months, even years for it to completely recover, right? So it takes a long time for the HPA axis to recover, and hence patience is very, very important, right? So a general rule of taper is that, like I said, you have to go from a more potent glucocorticoid to a less potent glucocorticoid. So let's say your patient is on a dexamethasone, then you go to prednisolone, and then you go to hydrocortisone, oral, right? Oral hydrocortisone is available in India. Again, a lot of doctors are not aware, but oral hydrocortisone is available as a brand called Hyzon. Again, no promotion of any brand, I am just telling you, right? I have no financial relation with this, but the point is that oral hydrocortisone is available in India. So you go from a more potent to a less potent glucocorticoids as you are going in terms of tapering. Okay, now here is where a very important concept I like to bring to you, and this is something, we have this discussion with our colleagues from pulmonology, colleagues from rheumatology. There is therapeutic taper versus endocrine taper. Especially I have this discussion quite often with a rheumatologist, right? Something very important we need to understand. Now, what is therapeutic taper? What is endocrine taper? Now, therapeutic taper means that you bring, so let's say the patient requires glucocorticoid for any condition that requires immunosuppression or whatever reason. Then what you have to do is you have to bring the patient's steroid down from the higher dose to the lowest possible dose as guided by the disease itself, right? So let's say patient has some form of rheumatological, let's say patient has SLE and his patient is responding to glucocorticoids, then you have to bring the glucocorticoids down to the lowest possible dose which the patient can tolerate and have least amount of side effects, right? So that's the therapeutic taper. Now, if the underlying disease does not require glucocorticoids anymore and the patient fits the criteria for tapering, then you have to bring the dose down to a physiological dose, right? Now, this is a very important point, right? You have to bring the dose down to physiological dose. What is a physiological dose? A physiological dose is typically 15 to 25 milligram equivalent of hydrocortisone or 4 to 6 milligram equivalent of prednisolone, okay? Simple rule, 5 milligram of prednisolone, right, or less than 5 is a physiological dose. So anything less than 5 milligram, 5 or less than 5 milligram is considered a physiological dose equivalent of a physiological dose of a steroid, right? So let's say a patient is, for example, let me give you, let's say patient is on, let's say having lupus and patient requires glucocorticoids, but now the rheumatologist feels that the glucocorticoid is not required, maybe a second line agent or some other steroid sparing agent can be given. Let's say the patient has been on 40 milligram, right? So then you have to bring that patient down to 5 milligram of prednisolone, right? And this is known as therapeutic taper, right? So this is the first phase of tapering, that is therapeutic taper, that is to bring the dose down to a physiological dose, right? So that's something which is very crucial and very important for anybody who deals with glucocorticoids. Now, next part is where the endocrinologist comes into the picture, right? So when you have done the therapeutic taper, I think what I'll suggest is any doctor who deals with any form of steroids needs to learn how to do therapeutic taper. Therapeutic taper is not endocrinologist domain. You can't send the patient for therapeutic taper. Therapeutic taper can be done by any doctor, right? So that's something which needs to be done by the treating doctor, whatever reason you have given steroids for or anybody else is given steroid, you need to do the therapeutic taper. But the endocrine taper has to be done by endocrinologists. This is something, what I strongly believe. Of course, the guideline says that, it can be done by some non-endocrinologists also, but I strongly believe that right now, in today's world, if you want to do an endocrine taper, so you want to stop the steroids. What I'm saying is the patient is brought down, now the rheumatologist has brought the steroid down from the whatever dose that was to the physiological dose, then his job is done. From bringing the physiological dose to 0, that is where the endocrinologist comes into picture, and that is where you do the endocrine taper, right? So this is something which is very important. So endocrine taper comes when the patient's dose is close to the physiological dose. This is where the tapering has to be done more slowly, more cautiously, and while assessing the HP axis. Again, you need to see and look for signs of adrenal insufficiency. So the idea is to balance between giving steroids and looking at the HP axis and recovery of HP axis, at the same time looking at the signs and symptoms of adrenal insufficiency. So you have to balance this out, and this balancing, because because endocrinologists are very keen at making a diagnosis of adrenal insufficiency or recognize this very easily. That's why this is something which should be done by endocrinologists themselves. So this is the taper sequence I already discussed to you. So patient starts, let's say a patient is on a supraphysiological dose of glucocorticoids for more than 3 weeks. So let's say a patient has been on let's say prednisolone of 40 milligram. Then first phase is to do a therapeutic taper, and therapeutic taper is to bring the dose down to 5 milligram equivalent of prednisolone, and then you do the endocrine taper. And this endocrine taper, what endocrinologists typically will do is to shift the patient from a prednisolone to a oral hydrocortisone. We generally give 10 milligram at 8 a.m. in the morning and 5 milligram at 4 or 5 p.m. in the evening, right? So this is a typical dose that we give. And then the endocrinologist gradually reduces the dose of hydrocortisone by 5 milligram every 2 to 4 weeks, looks for clinical cues of both adrenal insufficiency as well as glucocorticoid withdrawal, right, and keeps assessing the HP axis until you have complete recovery of the HP axis, and then you can safely say that the patient is completely off steroid, right? So it is not as easy as you think, right? There is a science and art behind it, right? And this is where the endocrinologist really comes into picture when you're tapering. Right, now when you're doing this taper, right, and this is where, when you're tapering the dose, there is a point of time where you have to keep assessing the HP axis, right? So a simplest way of assessing the HP axis is to measure the morning cortisol level, right? And the morning cortisol, remember, has to be checked. So if the patient is on hydrocortisone, so and just today, in fact, I saw a patient where we did this, right? So you have patient on hydrocortisone 10 milligram at 8 a.m. and 5 milligram at 5 p.m. So when I order the cortisol, the patient has to skip the afternoon dose of the hydrocortisone and do the test before the morning dose of the high zone, right? So that's the rule, right? So you have to do a morning cortisol with at least 24 hours stopping of oral hydrocortisone, right? So that's the typical way, and you do the morning cortisol level, and this is the interpretation of that. So if you are doing the morning cortisol, if the level is more than 10, that means the HP axis has recovered and the glucocorticoids can be stopped. If it is less than 5, then you need to continue the physiological dose of glucocorticoids till a few more weeks and then keep repeating. If it is between 5 to 10, this is where you can take a judgment call, right, depending on the clinical status of the patient, other things, right. Here you can use other tests also. So you can use something like an ACTH stimulation test, or you can consider using DHES. These are some useful tests for measuring in between levels, right. So this is how you typically do. Okay, so what I showed you earlier was the guideline as per the Endocrine Society guideline for tapering, but we have our own sequence for tapering, and this is based on multiple research papers. Again, this is not published, so we are not published this as a paper, right? So again, you need to kind of and Dr. Shambhu would say that why don't we publish this in the API conference as an abstract? Absolutely, would look forward to, right? It's a great idea, right? So what is our sequence? What is our taper sequence? What we typically do is we reach the physiological dose of glucocorticoids, then we switch to oral hydrocortisone, right? And we switch to oral hydrocortisone, we monitor the patient with a DHES value. Now, you would ask me why DHES, right? So DHES, remember, the thing about DHES is that DHES has a lot of benefits over morning cortisol level. First and foremost, you have to understand that when you are giving the oral steroid, right, oral glucocorticoid or oral hydrocortisone, sometimes the drug itself gets sort of cross reacts with the assay, and that the drug itself gets sort of recognized by the assay. But when you doing a DHES is something which is completely independent of the assays, right? So that means the assay cross reactivity of the assay is not there. Secondly, very importantly, DHES has a longer half-life compared to cortisol. It generally has a value which stabilizes over a period of 2 weeks. So it's like something like doing a glycated albumin instead of a random sugar, right? So it gives you a more longer period of time, a value for a longer period of time. So the HP axis, what you're assessing is over a period of 2 weeks when you're doing a DHEAS instead of just measuring at point blank, right? So that's something which is very useful. So what we do is, instead of measuring the cortisol, we measure DHEAS in our practice, and we serially look at the DHEAS values, right? Now, so write all my patients, on steroids, and when they are sent to me for tapering, I monitor it using the DHEAS, right? Now, serially see the DHEAS value. Now, if the DHEAS value has been serially increasing, now remember this point, okay? So again, let me show you this by diagram here. So remember, the ACTH, which is produced by the pituitary gland, that acts on the adrenal, right, to produce, remember, it does produce cortisol, but it also produces DHEAS, okay? So this is something which is essential to understand. Now, what happens is that, if the DHEAS, right, so what we are trying to do is, we are trying to see, remember, when you're giving steroids from outside, it is tertiary adrenal insufficiency. It's basically CRH and ACTH. So we are seeing the recovery of CRH and ACTH, okay? So to see the recovery of CRH and ACTH, we are using DHEAS as a surrogate marker. So that's something which I'm trying to illustrate. So what happens is that if the DHEAS patient is on steroid and the DHEAS value is increasing, what does it mean? It means that the ACTH is this axis upstairs is recovering, right? So it's a very assuring sign. So when you have a patient on glucocorticoids and DHEAS value is increasing, I often rapidly taper glucocorticoids. That means because it gives me a lot of assurance that the patient's CRH and ACTH are doing well, and I taper that very rapidly over a period of weeks. But if the DHEAS value is either static or reducing, that means that two things: either the underlying disease itself is a problem, or it means that the ACTH and the CRH axis, the HP axis, has not completely recovered. So in that scenario, I often see what is known as a DHEAS ratio. So remember, the problem with DHEAS is that DHEAS is something which changes according to the age and gender of the patient. So older people tend to have less DHEAS. So you look at what you do is you calculate the DHEAS ratio. DHEAS ratio is calculated by the actual DHEAS value divided by the lower limit for the age and gender, right? Now these values you can get from your labs, and you can also get it, sometimes it is printed in the report as well, or you can get, there is a paper in JCM, you can search for it, right? That paper also gives you the lower limit for different ages, right? So you calculate the ratio. In fact, we have made an app also. We're not still put it up, so we'll put it up. We have something called endodynamic, where we'll put that up, right? So if the DHEAS ratio is less than 1, that means that the DHEAS is not completely recovered, in which case you do continue the same dose or do a very slow taper. When it is more than 1.2, it is again quite reassuring, so you do a more rapid taper. If it is 1 to 1.2, that is where you do take a slow taper as well in that condition as well, right? So generally, if it is less than 1, here I say, of course I said slow taper, but I generally continue the same dose, right? I don't even reduce the dose of glucocorticoid, right? So this is something which I typically use in my practice for tapering of the dose of steroid. It's a little complex, but when you start using this, is actually very simple. This is simpler than the measuring of the cortisol, and it is less erroneous than measuring the cortisol. Now, I hope you enjoyed the sequence on tapering, but now let's go to the other aspects of adrenal insufficiency, that is looking at non-systemic glucocorticoids and do they lead to adrenal insufficiency. So the simple answer to this is yes. Okay, now inhaled glucocorticoids definitely lead to adrenal insufficiency. Topical application, rare, right? Depends on clinical situation. Sometimes if the patient has had a very severe loss of skin and very potent topical steroids have been used, that can lead to adrenal insufficiency. Intra-articular glucocorticoids, and the new guidelines, of course, this slide I had made some time back, but the new guidelines categorically says that intra-articular glucocorticoids potentially definitely leads to adrenal insufficiency. Intranasal spray, rarely, it doesn't generally lead to adrenal insufficiency. Ophthalmic application does not lead to adrenal insufficiency. So the ones which are really concerned about are inhaled glucocorticoids and intra-articular glucocorticoids or steroids. These are the ones where adrenal insufficiency is particularly known to happen and particularly something you have to look out for. Now, inhaled glucocorticoids, you have to be cognizant of this fact that not all of them are directly deposited in the lung. About 10 to 60% gets deposited in the lung, but 40 to 90% gets orally swallowed. So even though inhaled glucocorticoids are better than oral glucocorticoids, some of it is swallowed and then definitely has systemic effects also. So you have to understand that it is not all rosy. Inhaled glucocorticoids are not 100% safe, they definitely lead to HPA axis involvement also. And particularly remember the potent steroids, right? So fluticasone, right, is particularly potent and particularly nasty when taken for a long time to lead to adrenal insufficiency. So that's something you have to be very well aware. Inhaled fluticasone is something you have to be aware about and can lead to adrenal insufficiency. So again, if you're, and see, if you're dealing with a COPD patient, this is something you have to be well aware about, especially perioperative period and other situations, right? So you have to be careful about these things, right? Now, let us then, so we looked at the glucocorticoids. Now let's look at some other drugs that can lead to adrenal insufficiency, because today's topic is not just looking at steroids, but looking at all the drugs that can lead to adrenal insufficiency. So we'll talk about 6 different drugs. I'll tell you some stories about these patients also. Very importantly, anti-cancer drugs. This is something you have to be, any patient on oncology therapy, right? Lot of these oncology patients have adrenal insufficiency, lot of them, right? So you have to be very careful. Drugs itself can lead to adrenal insufficiency. Also remember, a lot of these patients are on chemotherapy, and when chemotherapy is given, a lot of these patients are given dexamethasone. So it is very important to understand that these patients will have adrenal insufficiency unless proved otherwise, right? This is something which oncologists also need to understand, and any oncosurgeon who operates this patient also needs to understand that this is something which is very important, right? Now, the earlier study which I had shown by Rashi, what Rashi had also shown is that the changing phase of adrenal insufficiency, I can see from here, earlier, a lot of these cases where most of the adrenal insufficiency cases were reported because of steroids, but these days, and this yellow is basically, I'm sorry, that got cut off, right? So yellow is basically representing the, the immunotherapy, right? And the number of reported cases of adrenal insufficiency because of immunotherapy has rapidly increased over a period of time, right? So that's something we have to be very well aware about, right? And that's something we have to be cognizant about, right? Now, the immunotherapy, the important drugs that can lead to adrenal insufficiency, you have this immune checkpoint inhibitor, right, which is called as ipilimumab, right? This can lead to pituitary involvement. So it can lead to secondary and tertiary. So it leads to hypophysitis, right? It leads to pituitary involvement known as hypophysitis, and that can lead to adrenal insufficiency. And the PD-1 inhibitors like nivolumab, these are very popular in India, can directly lead to adrenal involvement, sometimes can lead to thyroid involvement also, and can lead to pancreas involvement and type 1 diabetes also. But they can lead to primary adrenal insufficiency. So they can directly involve the adrenal gland, leading to primary. And we had a couple of patients with these type of things as well, right? In fact, we had a lot of patients with immune checkpoint inhibitors on, leading to adrenal insufficiency. Another very interesting drug and very important drug that can lead to adrenal insufficiency is abiraterone. Now, abiraterone is a very popular anti-cancer drug for prostate cancer, right? And it almost certainly leads to adrenal insufficiency. In fact, the oncologists who give this drug are aware of this fact, and they also simultaneously give glucocorticoids in these patients on abiraterone, right? Now, abiraterone, remember, is a CYP17 enzyme inhibitor, and it directly inhibits the cortisol pathway. Because it directly inhibits the cortisol pathway, it leads to adrenal insufficiency. It's very simple mathematics. There is no complication about it. Unfortunately, this is often missed out, right? We had this patient who was, who had some problem and then got admitted in some hospital outside, was very sick. Patient was on abiraterone, which one relative knew about it, but the other relatives did not know about it, right? So patient got admitted, patient developed hypertension, developed other things, and ultimately the patient ran away from that hospital. The patient was shifted to our hospital. When the patient came to our hospital, right, we started taking the history, and the other relative who actually knew about the patient better came and said that he's on some cancer drug. I said, what cancer drug? So he had prostate cancer, he was taking some drug for cancer. Immediately, my sort of bell started ringing. So I asked him to bring the drug. It was abiraterone, and we started the patient. Patient actually had adrenergic crisis, and we started the patient on glucocorticoids. Patient became better. Patient went home, right? So I think that's something which good history taking again is something which is very crucial and sometimes often missed out. Another very important drug that leads to adrenal insufficiency, and that is what again we all need to be aware about, right? This is very popular drug, very frequently used and misused, right? That is tramadol. Okay, tramadol is a very important drug that can lead to adrenal insufficiency. Tramadol, long-term use especially, can lead to HPA axis suppression and can lead to adrenal insufficiency. So it does lead to tertiary form of adrenal insufficiency, and that's something which is very crucial and very important for you to understand. And this has been proven in humans as well as in clinical experimental findings in rats also. So long-term tramadol use, in fact, we had about 5-6 patients on our follow-up who are tramadol-induced adrenal insufficiency, right? They've been taking tramadol for a long time, and they have this typical history, right? Another in the similar class, opioids, right? Now, again, a lot of, I don't know, if it's common in your parts of country also, but we see a lot of patients in Gujarat, we see a lot of patients from Rajasthan, Haryana and Punjab, and the amount of opioid used in these states is tremendous, right? I'll be really surprised that a lot of patients, almost every third patient is on Afim, right? And Afim or opioids or marijuana, right? All these things lead to adrenal insufficiency, especially chronic use, right? Very, very common, very, very important, very commonly missed out, right? So opioids, especially chronic opioid use, whether it was for recreational use or sometimes therapeutic use also, like for example tramadol, also you can consider the same group, can lead to adrenal insufficiency. Again, we had one patient with classical adrenal insufficiency because of opioids, right? Again, leads to tertiary adrenal insufficiency, so that's something you have to be aware about, right? And this patient was classic. Again, a lot of people missed out the diagnosis. We made the diagnosis, patient became better, right? Now, another fifth fact and very important fact, and this is our paper which was published. This is a paper published by us, right? A case report which was published by us. So levothyroxine, right? Now levothyroxine, in fact, this has been quoted in the earlier article. Our paper has been quoted, saying that levothyroxine, as a reference has been quoted. The point I'm trying to make is that of course, levothyroxine itself does not lead to adrenergic adrenal insufficiency. It can unmask an adrenergic crisis, right? So a patient who has simultaneously adrenal insufficiency with hypothyroidism, if you treat the hypothyroidism first, the patient's adrenergic crisis, the adrenal insufficiency can get unmasked and can precipitate an adrenergic crisis. This is exactly what happened in the patient which we had reported as a case report. So that's something which you have to be very, very aware about. Again, in a patient with a pituitary disorder also, when you have both the hypothyroidism as well as adrenal insufficiency, when you treat the hypothyroidism before adrenal insufficiency, then you can precipitate a crisis. So that's something, again, you have to be well aware about in your practice. Fact number 6, CYP3A4, right? 3A4 induced adrenal insufficiency, or drugs or substances that inhibit CYP3A4 like grapefruit can increase cortisol level, right, by reducing its metabolism. But the drugs like rifampicin that increase cortisol metabolism, so that's something you have to be aware, right? So when you have CYP3A4 inducers, the patient can have adrenal insufficiency, or the patient is on steroids. So let's say a patient is on glucocorticoids, patient has adrenal insufficiency, and you introduce rifampicin, then you need to increase the dose of the glucocorticoids to prevent adrenergic crisis, right? So that's something you have to be very well aware about. Again, clinical pharmacologists are well aware about these things. So again, as clinicians, we also need to be aware about these things, right? So rifampicin, remember, rifampicin has been reported to produce adrenal insufficiency. It can in fact worsen existing adrenal insufficiency in patients with tuberculosis. A lot of patients with tuberculosis have adrenal involvement. This has again frequently been reported in a lot of case reports and across the country. And patients on physiological glucocorticoid doses need to increase the dose when glucocorticoid has been prescribed, right? So rifampicin is something you have to be well aware about, right? So these are the points, right? A lot of drugs, of course, I did not cover. Ritonavir, I already told you, right? Important cause, and fluconazole, right? Fluconazole, itraconazole, all of them can lead to adrenal insufficiency. So these are something you have to be, again, well aware about and be cognizant of these facts, right? Now, how to recognize, diagnose and treat adrenal insufficiency? Again, how do you establish the diagnosis? So this is again our own, sort of flow chart. Very interestingly, this has been now replicated in a lot of guidelines. Very similar. Again, I will not take credit for these things, but sometimes great minds think alike. That's again what I'll say. So how do you assess the HPA axis, or how do you look for adrenal insufficiency? So what to do is a morning cortisol, DHEAS and DHEAS sample in fasting. So whenever I'm looking at adrenal insufficiency, I do send these samples in morning fasting. If the value is less than 5, definitely the HPA axis is compromised. If it's more than 12, it is generally considered to be normal. But if it is between 5 to 12, that is where you are looking at the somewhere in middle, right? And here we look at the DHEAS ratio. Okay, so DHEAS ratio, again, I already told you. Now in that context, the ratio we are seeing in a little different way. Here we are seeing with a more margin ratio. So if it's more than 1.8, it is considered to be normal. Less than 1, it is considered to be HPA axis compromised. And 1 to 1.8, this is where you go for a ACTH stimulation test. And this is the little app we had made for calculating the DHEAS ratio. This I use in my own practice. But again, it's not available for you, but we'll make it available, right? Like, Dr. Shambhu said, I'm very interested in AI and computational medicine, etc. So this is something which is part of my a little bit of a project. So if the value is between 1 to 1.8, that is where you do a ACTH stimulation test. And if the post stimulation cortisol is more than 18, HPA axis is normal. If it is less than 18, HPA axis is considered to be compromised, right? So that's something which is very important, right? So this is the protocol for ACTH stimulation test. Again, endocrinologists listening to this don't need to be taught this. Is very simple. This is, they already understand this. Remember, you don't need to have a fasting sample, or you don't need to have, you can directly, anytime the patient comes, you can administer 250 microgram of synactin, and you have to take a sample at 0, 30 and 60 minutes. A zero sample is not necessary again, right? So even though the, this is from one of the guidelines, but a zero sample is not required. You can directly do a 30 and 60 minutes. If patient already you're done, I'm assuming that a fasting baseline cortisol has already been done. Right now, if any of this value is more than 18, it is considered to be normal. If it's less than 18, that means that the HP axis is compromised. So that is the ACTH. This is called high dose ACTH stimulation test. There is another one called low dose, which uses 1 microgram of ACTH. But again, we'll discuss that in a separate forum. I think that is something which is important, right? So morning cortisol less than 5 has 100% specificity and sensitivity for making a diagnosis. However, there are certain guidelines say which less than 3, but I think again it's err on the side of caution. I think 5 is a better cutoff to deal with, right? Upper limit, the rules of adrenal insufficiency is again newer guidelines and newer studies says 12, older guidelines used to say 18, right? But again, that would depend. Remember, the cortisol value depends on the clinical circumstance also. So you have to look at the physiological stress, and again, if you're not very sure, it's always better to send it to an endocrinologist who will be able to do better, right? So we already looked at ACTH stimulation test in detail, okay? Now, when you have already established that the patient is having adrenal insufficiency, you want to see whether it is primary or secondary versus tertiary. In that case, again, something which is very useful is to do a ACTH level, right? And if the morning ACTH level is more than 100, if it is definitely primary. If it is less than 20, it is secondary or tertiary. If it is between 20 to 100, that is where the gray zone lies, and that you may not be able to very clearly recognize whether it is primary or secondary or tertiary. Actually, it does not make too much difference in management, except for the fact that primary adrenal insufficiency you will be giving fludrocortisone, whereas other cases you will not. DHEAS we already discussed about, right? So it's a useful test as and it's an emerging test which is very important, right? Finally, the last part of my presentation is management of adrenal insufficiency, and the management, primary adrenal insufficiency. When a patient comes in an acute crisis, you give IV hydrocortisone, and in chronic cases, you give oral hydrocortisone or oral prednisolone or an oral fludrocortisone. Now, DHEA supplementation is an area of debate. Again, completely different debate, completely different topics. We will not discuss here. But what I already told you this earlier, that primary adrenal insufficiency, you give high zone oral hydrocortisone with oral fludrocortisone, right? So that's something which is useful. And secondary adrenal insufficiency or tertiary adrenal insufficiency, again in crisis you will give IV hydrocortisone, but in chronic cases you can give oral hydrocortisone or prednisolone. I do not prefer dexamethasone. So again, it's not a very good idea to give dexa, even though of course this is taken from some guideline, but preferably to give oral hydrocortisone or oral prednisolone, right? So to summarize, some practical take home message. Remember, first about glucocorticoids. Glucocorticoids given more than 3 weeks in doses more than 20 milligram per day of prednisolone or equivalent can compromise HP axis. In such cases, tapering of steroids are required. Non-systemic glucocorticoids like fluticasone or inhaled glucocorticoids can lead to adrenal insufficiency, and drugs like anti-cancer drugs, rifampicin, tramadol, all of them can lead to adrenal insufficiency. So again, you need to be vigilant. Third take home message, DHEAS, a very useful test for early diagnosis of adrenal insufficiency, and it's also useful for follow-up of patient with tertiary or patients on tapering, right? DHEAS is a very useful test. So again, one of my favorite tests. All my lab people know that if DHEAS is sent, it has to be ohm, right? So that's the idea. So thank you for a patient listening, and now hand it over back to the organizers.